talk today about the diagnostics, the pathogenesis, and prevention measures, hopefully some vaccines in the pipeline for these emerging infections. So we'll start with Phyllis.
Thank you, Dr. Stevens, Dr. Farley. Can everybody hear me? I wanted to say first that Dr. Mulligan and I have no conflicts to report. And let's talk about our objectives for the next hour. We'd like to better understand the epidemiology of dengue, chikungunya, and Zika. We'd like to identify the clinical manifestations, the distinguishing characteristics and complications of these diseases, learn prevention strategies for the community, for yourself and your families, compare the limited knowledge of Zika natural history to the more extensive knowledge base for chikungunya and dengue, and to understand the challenges in diagnostic testing and the advances and challenges in vaccine development for these diseases. We'll start with a case today. And you'll see this patient presented in December 2013. I want you to remember that. It's a 30-year-old man. He presented with a high fever, myalgia, some retroorbital pain, arthralgias, and conjunctivitis. His lab data showed a white count that was a little bit low, but the rest of his routine labs were normal. He had malaria testing done because he had traveled, although he hadn't traveled to a malarious area. On day 3, he developed a rash, maculopapular rash on his back, his trunk, his arms, but he improved spontaneously by about day 10, although he felt fatigued for weeks. Well, what do we think about the differential diagnosis here? Obviously, it could be a whole host of viral infections, enteroviruses, but we're talking about these 3 emerging diseases. And frankly, it could be either of those as well. Let's put this gentleman aside for a few minutes and we'll come back to him. He's stable. Where was he? When we talk about travel-related or tropical diseases, the most important part of that is to know where somebody was and when. There are other factors as well that come into the diagnosis, but it's very important to know where somebody was. Now, this gentleman was in a wonderful place. He was in Tahiti and Bora Bora in French Polynesia. Let me remind you of where this is, okay? Because people say South Pacific, and it sort of has this vague feeling of where that is out in the Pacific Ocean. And certainly it is. It's out in French Polynesia, which is about almost 3,000 miles south of the Hawaiian Islands, and as well southeast of some of our territories and relationships that are in Micronesia or Guam, Saipan, the islands of Yap, Midway Islands. So I want you to sort of remember where this gentleman was in December of 2013. And we'll move on. Well, why have these diseases emerged? Whenever we see something new, whether it's Ebola or Marburg or Lassa or Zika, we say, what the heck happened here? Why is it here, and why can't we get rid of it now? First of all, population growth all over the world, but particularly these megacities in developing countries. People are migrating from rural areas to have a better life, to get better jobs, and forming these megacities in developing countries. At the same time as there's urbanization, as we said, people are moving from rural areas to these large cities. There's a lack of sanitation and public health infrastructure. So you can imagine if a small percentage of people moving into these cities have sewers and public water supply, they have to travel, get water, clean water, bring it back to their homes and store it inside and outside. Now, this stored water is in containers, which, as you know, stagnant water is a wonderful breeding ground for mosquitoes. And you see in the picture here what these cities look like now, because in the last 20 years, we have plastics that are non-biodegradable. So waste areas fill up with plastics and containers that fill up with even small amounts of water, which are great breeding grounds, along with used old tires for water and for mosquito larvae. Virus and mosquito adaptation have occurred and climate change, and there's been really a lack of vector control with focus on outdoor spraying of mosquitoes that have not controlled diseases in the past, and air travel and trade, which is a big one. If we look at just commercial airline arrivals, it's doubled since 1996. We've got greater than 1 billion passengers traveling and arriving in places annually. This is just commercial aircraft. This does not account for people who are migrating on the land, who refugees going from country to country. So if you look at the increase in just commercial aircraft arrivals from jet travel, it's enormous. This is an old slide, but a good one, I think, which shows the massive increase in population in the last about 160 years. At the same time, as you see on the red line, the days to circumvent the globe have gone from an entire year down to a day. So you can just about go from one place to any other place in the world within a day or two. That's a huge difference. Moving to the arboviruses, and these 3 viruses we're talking about today are arboviruses. R because they're arthropod, bo because they're born, arthropod-borne viruses that are transmitted in general by mosquitoes and ticks. And this just is an example of chikungunya. This should say sylvatic transmission cycle. That's the cycle that for many, many, many years, decades, and millennia have gone on in the forests, say, of East Africa, where you've got mosquito, non-human primate to mosquito to non-human primate to mosquito again. So that's the way these diseases circulated. And all of a sudden you've got people moving from these forested, rural, swampy regions to our huge urban megacities. What happens? You've got some changes in evolution. Mosquito populations start picking up the viruses from our incidental hosts, which are not just non-human primates, but become humans. And then so the cycle starts developing in the urban area. You've got Aedes albopictus and Aedes aegypti in our urban areas, and that starts the whole urban cycle of transmission of these diseases. So movement of large groups of people, and then the change in the virus from going from the mosquitoes of just the forested regions to our urban areas. The first disease we'll talk about is dengue, or breakbone fever. The reason it's called breakbone fever is because people who have it feel like their bones are broken. They feel like they've been run over by a truck. This is an old disease. It's been around for a long time. We had major outbreaks in the 18 and 1900s in this region of the country, certainly through the whole Gulf states, along with malaria and yellow fever. The virus was finally isolated in Japan in the 40s, and there were major outbreaks throughout Asia and Southeast Asia in the 1950s. What happened here? We did a great job in eradicating mosquitoes from the Americas, starting in the 1930s before DDT and up through the 1970s. It was why really the CDC was born in Atlanta, to get rid of malaria in this country. It was very, very successful. And so we got rid of the Aedes mosquito, the Anopheles mosquito, and all things were great. We became very complacent. The money disappeared, and many of these countries that had had Aedes and Anopheles mosquitoes had certainly other challenges to deal with throughout the 70s and 80s. So mosquito eradication and controlling mosquitoes became a very low priority. Unfortunately, with the 1980s came a resurgence of dengue. And as you can see from this chart, it started around in 1980 and all the way up to 2010, when we see almost 2 million cases, again, of dengue fever in the Americas. These are the endemic countries now. Unfortunately, it's gone all through tropical and subtropical South America, Central America, Mexico, and the islands again. I put stars next to the Dominican Republic and Uruguay because there are ongoing outbreaks there currently. There is a red star on Hawaii you can see in the upper left because the governor of Hawaii declared a public health emergency in February of 2016 because we had almost 300 cases of dengue on the Big Island. They've had some better control of it right now, so they've stopped the public health emergency, but as you can see, we still have a problem that even creeps into the United States as well. As of January and February, just 2 months this year, we've had already 200,000 cases of dengue in the Americas. If we look into Asia and Southeast Asia, where this disease is still rampant, there are outbreaks currently in Thailand and New Guinea, and usually we see about 250 million cases a year of dengue. Clinical picture: fever, myalgia, arthralgia, rash. All of these 3 diseases can present pretty much the same. This tends to be more severe disease. Only about 25% of people, though, with dengue will be symptomatic. Incubation period is fairly short. Sometimes the white count is low. Sometimes the platelets are low. About 5% of people will develop hemorrhagic disease, which is quite severe and causes significant number of deaths per year. Dengue hemorrhagic fever and dengue shock syndrome. The duration of the disease may not be too long, but there is a post-viral asthenia that can go on for quite a while, weeks to months. The next disease is chikungunya. Chikungunya is from one of the Bantu languages, and it means to be bent or to be bent up. And that's because the people who have chikungunya look bent because they have so much pain in their joints. Outbreaks of a chikungunya-like disease were recorded for many years in Asia and Southeast Asia through 19th and 20th centuries. The virus was first isolated in 1952 in Tanganyika, which is really current Tanzania, in eastern Africa, that's just south of Kenya. Then there was a large outbreak in Kenya in 2004, which spread over into the islands that are just east of Kenya, the Comoros Islands and Réunion. And these have very strong relationships that have gone on for many years with the mainland in Europe, with France in particular. So there was a lot of travel ways between Réunion and southern France and Marseille, and all of a sudden there were cases in southern France, local transmission, meaning it wasn't just travel related in southern France and Marseille, and as well in Italy. It continued to brew that way in some parts of Africa and in southern Europe until October of 2013, when cases began to be reported in Saint-Martin. And again, local transmission started. Local transmission means indigenous mosquitoes. We call it autochthonous transmission. Indigenous mosquitoes were biting people in Saint-Martin and causing an outbreak of chikungunya. It continued to spread in this non-immune population through the Caribbean, Central America, northern South America, and to Florida, where we saw 11 locally acquired cases, and they were reported. That caused a lot of concern, especially as we see dengue outbreaks and chikungunya. So public health in Florida is really on the alert for these diseases right now. Since 2013, local transmission has been identified in 45 countries or territories throughout just the Americas, with greater than 1.7 million suspected cases reported. So it's a significant, significant problem. The clinical picture, again, is very similar to dengue. People have fever, myalgia, headache, rash, incubation period usually pretty short. The big difference here is the arthritis and the arthralgias. People can have such severe arthritis that even when it goes away, it relapses, and sometimes it comes back and becomes chronic and erosive, so that people have an immune disease that mimics rheumatoid arthritis. And there's a lot of discussion now about the best ways of managing chikungunya arthritis. There are rare deaths with this disease, but certainly it's significant. I put this slide up because I saw this comment in the paper recently. Tata Corporation is a multinational Indian company that has tentacles in a lot of areas, and they manufacture cars. You may know that they purchased the rights to Range Rover and Jaguar, but they decided to manufacture a really cute little sporty car, a hatchback, that they named Zika. And then in February of this year, they realized that maybe it wasn't the best idea. So they decided to ask the public what they should name it, and they had all kinds of names coming in. And they finally decided on Tiago, which I read and was told that that means James. So I guess they decided that they had such a high-profile name that they wanted to change it to something else. Well, Zika virus was first discovered in the Zika forest in Uganda in 1947. But it would crop up just sporadically in non-human primates and humans in Africa for quite a long time. Then in 2007, there was a huge outbreak in Yap. And you might say, where the hell is Yap? And that's where our maps come in really, really helpful again, and I'll show you. Yap has a population of about 12,000 people. It affected 75% of that population. It's a group of about 4 islands, again, in Micronesia, in the Pacific. And it's have beautiful coral reefs around it, but the island itself is very swampy. Then it spread from Yap and Guam southeast into other Pacific islands and into Polynesia and French Polynesia. From there, over the last year or two, there was reported local transmission on Easter Island. And you might say to me also, what's Easter Island got to do with anything as well? Let's take a look at a series of maps for a minute. There you see in Central Africa, a little orange blob there. That's where it started in Uganda in 1947. Okay, in the 70s, it stayed in Uganda but moved a little bit west into some of the Western African nations. Gabon had a little outbreak. Nigeria also spread eastward into Malaysia and Indonesia, some cases in Pakistan. As we move on, here we are in 2007, and Yap is up there in the Pacific with the Micronesian islands that have a loose connection sort of to the United States. Yap was discovered by the Spaniards, purchased by the Germans, used as a cable trading post, sort of in World War I. Then the Japanese sort of took it over in World War II, and then the U.S. ended up with it after World War II. So Guam and Yap are really have a close relationship with the United States. Then here we are in Tahiti and French Polynesia in 2013, if that reminds you of something we talked about earlier. Another major outbreak in French Polynesia. We had about 30,000 cases with a population of 250,000 or so. So that's a significant number of people in French Polynesia became sick. Then we continue to move south and eastward, and we're still in the middle of the Pacific Ocean when we see over there on the left-hand side an arrow moving on to Easter Island. Easter Island is one of the most remote places in the entire world, a very small population. But what's the issue with Easter Island? The issue with Easter Island is it's part of Chile in South America. And during festival seasons, there are flights filled with people, hundreds of people every day, that go back and forth between Santiago and Easter Island, back and forth and back and forth. So all of a sudden, there are cases in Chile. And then all of a sudden, we have air travel, significant air travel between Santiago and Brazil. So here we are on May 15th with Brazil reporting their own indigenous cases of Zika infection. And now into Central America, Northern South America, and the Caribbean. So that's how the movement of diseases occurs. Let's come back to our gentleman here who was in French Polynesia in December of 2013. And indeed, he did have Zika infection. As you recall, French Polynesia, Tahiti, and being not so far, or we think far, but it's not so far from these other places where it's spread. Zika virus manifestations and observations. Like dengue, a small number of people who are infected become symptomatic, about 20-25% of people. Incubation period short, fever, rash, arthralgia, some conjunctivitis. For the most part, it was a mild disease. I presented this case in 2014 at our Clinical Case of the Week conference in infectious diseases. And I said, we'll be seeing this disease soon. But I was so thrilled because I said, don't worry about it. It's a mild disease. People don't get that sick with Zika. And usually they don't. Unfortunately, the observations are there's a temporal association, strong one, with post-viral Guillain-Barre. There's an association, as we know, with microcephaly and other prenatal and neonatal abnormalities. There are now almost 6,000 cases of microcephaly reported in Brazil in 5 months, when usually in a year they report about 160 cases. There's also, looking back, reported association of microcephaly with the outbreak in French Polynesia. And we know, unfortunately, now it can be sexually transmitted. The differences in these diseases: Zika more likely will have a rash and conjunctivitis and be a milder disease in general. Dengue will be a more severe disease and has the likelihood, and as we said, in about 5% of cases, to become dengue hemorrhagic fever, dengue shock syndrome. And chikungunya often has associated severe polyarthralgias and, unfortunately, polyarthritis. So in mid-January, because of the concerns about microcephaly, CDC put out a travel warning recommending pregnant women in any trimester postpone travel to areas with Zika transmission. Also, men who have had potential exposure to Zika and who have pregnant partners should use condoms for the duration of pregnancy. Additionally, men should practice abstinence or use condoms for 1 to 2 months after travel to an area with ongoing Zika transmission, and for 6 months following recovery from Zika infection. This is quite interesting, and it's very difficult. Symptomatic travelers should ideally abstain from sex pending testing. There are significant issues with these guidelines and recommendations, but they're out there now, and for good reason. Over 30 million Americans travel to Central and South America and the Caribbean every year. As of March 9th, and as of today, I think there are about 209 U.S. travelers reported with confirmed Zika. We have had no local transmissions in this country as of yet, except sexual transmission. In returning travelers, we've already seen miscarriages, evidence of birth defects, elective terminations of pregnancy, and some of the women are still pregnant and they're being watched. Obviously, there are major concerns about events coming up this summer, such as the Olympics and Paralympics. Last item is, what's the problem with this mosquito? They're aggressive day and nighttime biters. They prefer to bite humans. They live indoors and outdoors with us. The top map shows where Aedes aegypti, which is the most prominent disseminator of Zika infection now, where they are in the United States. The bottom map shows Aedes albopictus, that has also been a transmitter of these disease arboviruses such as chikungunya. And the concern is perhaps Aedes albopictus will become an adequate vector and will be able to transmit the disease as well. I think this kind of modeling is a little bit of fear-mongering, but I do think that people need to be aware of the concerns. Disease prevention, last in the community. Improved disease surveillance. Diagnostics is a problem right now. Emptying containers of water, using pesticides and particularly larvicides, both indoor and out. Use repellents, impregnated mosquito nets and curtains. Clean up waste, plastic containers, old tires, and other refuse that holds water. And there are some very new and exciting things about releasing genetically modified male mosquitoes, as has been done in certain areas, that will render eggs unable to develop into mature mosquitoes, and using irradiated mosquitoes. As well, using a bacteria that lives symbiotically with mosquitoes, Wolbachia. When introduced into Aedes, it reduces vector competence. And last, for personal protection, use an EPA-approved insect repellent. Consider permethrin-impregnated clothing. Wear long-sleeve shirts and pants when you tolerate it. Use netting on stroller and cribs, and mosquito nets and knockdown sprays if you're not in an air-conditioned dwelling. I think we'll stop here and let Dr. Mulligan continue. These were advertisements on eBay that I saw. The amazing thing is the impregnated dress that doesn't cover this woman's arms and legs. But it's a bargain.
All right, it's a pleasure for me to join Phyllis in addressing you today about this important topic. Here's an outline of what I'll talk about: diagnostics, virology, pathogenesis, and then a bit about vaccines. And I think we have to be very humble. A lot is unknown. There are things that we know, things that we know we don't know, and there's probably a lot that we don't know we don't know. So for acute phase diagnostics, we'll start with this. PCR is a test that's being done mostly at CDC, and it's beginning to get out into the state health departments now. The test can be used in the first 5 to 7 days after symptom onset when there's viremia on blood or serum or plasma. And RT-PCR is the preferred test for all three of these pathogens. The viremia decreases over time so that a negative PCR at 5 to 7 days doesn't rule out one of these infections. Importantly, the viral RNA actually persists longer in urine and also in semen. And so this is something that's being developed as potentially a diagnostic test in urine to give us a longer window for detection of acute or early convalescent infections. So PCR for early testing. And here's a picture. The red is the viral load in a dengue case in blood. And you can see it's generally gone after about a week. And antibody starts coming up, usually day 4 or 5. May not be detectable, though, and there's a window period here, potentially, between the viral load having fallen off and antibody coming up in someone who's naive. There's also an antigen test for dengue, NS1. There are no antigen tests for Zika or Chikungunya. In fact, there are no FDA-approved diagnostic tests for Zika at this time, although a number are preparing for submission. So what about antibody? This can be detectable, as I said, starting 4 days after symptoms, and will last, the IgM can last up to 3 months. It's necessary to confirm a positive because of dengue and other flavivirus cross-reactivity, and this is a real problem with the diagnostics. The biggest problem for the last couple of months has been the backlog. I had heard from CDC a couple of weeks ago that they were getting 600 tests a day at their Arbovirus diagnostic facility in Fort Collins, Colorado. So it's very important that they get the tests out to the states, and they're in the process of that now. And I heard, although I haven't been able to confirm, that our state now has the test, at least one of the tests. Okay. Here is a CDC algorithm, and I'll show you this for suspected cases. Molecular testing again, so PCR for less than 7 days after symptom onset. There's a specific test for all 3 of these pathogens, and if it's positive, you have a one time point positive result, and that's it. You're good to go. Antibody testing can be used starting 4 days after, and there's an IgM test for all of these. And if it's positive, it's just presumptive because of the cross-reactivity. For example, if I have a positive Zika test, that might be due to dengue or chikungunya for IgM. And so then it's necessary to do a neutralization assay, which is what PRNT is, plaque reduction neutralization test, for resolution of that and get more specificity. It's a busy slide, a little confusing. This was actually a report from a 2008 researcher who went to Africa and caught Zika along with his colleague. He came home and there was sexual transmission to his wife. She's patient 3. She had not traveled, had not been vaccinated against yellow fever. The A is the acute and then the convalescent testing. So her PRNT neutralization test was negative acutely, but it clearly went up with her convalescent sera a couple weeks later. But very interestingly, the husband and the other scientist who traveled both had gotten yellow fever vaccine, had been in country there for about a month, may have gotten dengue as well. So their acute sera are quite high for neutralization tests, but their Zika is high as well, and you can see the Zika is increasing. But it shows you the cross-reactivity. Probably in this acute time point, it's not Zika that's causing this result. It may be that they're having an anamnestic response to the yellow fever vaccination they got that is cross-reacting on the Zika test. So it can be very confusing, and I think this has been a part of the delay in getting the diagnostics out while they've been sorting out how to do these tests. Since that was a sexual transmission case, I'll just mention that it's very clear now that in several publications that Zika is present in semen and urine and can be there much longer than it is the 5 to 7 days in blood, perhaps weeks and even months. Lots of information coming out. Phyllis and I were saying in preparing for this Grand Rounds, it was a little bit challenging because every day or two over the last few weeks there are new studies coming out in the literature. This is a very fast-moving field right now. And then very recently in Lancet, a report of virus particles in breast milk, and these are infectious virus particles. They took the particles, put them on Vero cells, African green monkey cells, and showed that the virus could replicate there, that came out of breast milk. Same has been done for virus coming out of semen and urine. It's infectious virus. A little bit of virology, just backing up a step. So we have 2 flaviviruses today and 1 alpha virus that we're talking about. Zika and dengue are the Flavies. Flavy is the Greek word for yellow, and that comes from one of the cousins, yellow fever virus, which is the dominant virus in this group. Sometimes dengue, but yellow fever can cause a severe hemorrhagic fever. You heard 5% of the time you can get the severe dengue shock syndrome and dengue hemorrhagic fever. Most of the time with dengue and Zika, it's a rash, fever, arthralgia, conjunctivitis, as you've heard. There are a number of flaviviruses that cause encephalitis, and I'm listing them here. And then there's the alpha virus. The alphas are closely related to the flaviviruses. They're in a different family, the togaviruses. And chikungunya is the alpha virus that we've been talking about today. These are the flavivirus structures. It's about 40 to 50 nanometers. A good benchmark is HIV is about 100 nanometers, in diameter. So these are about half the size. These are positive sense RNA viruses. They bud into cytoplasmic structures. So you're seeing them inside of cells here in this transmission EM that CDC released recently. Here's the genome of Flavies, including Zika. You have a capsid protein, the pre-membrane protein, the E or envelope protein, the major surface protein shown in yellow here in this cartoon, and then a variety of NS or non-structural proteins, which include the protease that cleaves the polyprotein and has the viral polymerase as well. So I'll move into pathogenesis. This is probably the first report that came that began to really start to suggest that we were getting more than an association, potentially causation for the virus and birth defects. This was a woman from Slovenia. It's a case report in New England Journal a few weeks ago, who went and was volunteering in Brazil, went home. Her baby on ultrasound, she was pregnant, had an illness while she was in Brazil. Her baby had growth retardation. They did ultrasounds, and there were calcifications in the brain. She had an elective termination in the early third trimester. She was fine at that point, but in the brain of the baby, which had microcephaly and many other birth defects in the brain, and there was also calcification in the placenta, but they were able to see virus particles in the brain. And not only that, there was a large amount of virus genome in the brain of the fetus. They pulled out a complete sequence of the genome there from brain tissue, again suggesting a strong neurotropism of this virus. There's a report out, I think yesterday or in the last couple days, from in one of the Cell journals, Cell Stem Cell, showing that the virus can infect neural progenitor cells and beginning to start to nail down more some of the pathogenesis. It's interesting that the virus persisted and was present in fetal brain some 8 months, 7-8 months after into the pregnancy, whereas the mother had been fine for many months. So this immunologically protective site, I think this is also why there's virus in testis, in eye, and other locations. So the risk of neurotropic and teratogenic virus infections places a high emotional and economic burden on society, and I think this is one of the reasons Zika is catching a lot of attention. Another report that has come out in the last week or two online, March 4th, also in New England Journal, from Brazil, where from September of 15 to February of 16, 88 pregnant women who had had a rash in the last 5 days were enrolled in the study. 82% of them had a positive result for Zika RNA during their acute illness, in blood, urine, or both. You can see there are some that only had it in the urine, some that only had it in blood, some that had it in both. The amount of virus in urine had a lower cycle threshold, so it was a higher amount of virus in urine than in blood. Of the 72 that were Zika positive out of the 88, 2 had miscarried. Of the remaining 70 Zika positive women, 42 had ultrasounds. There were 28 that either didn't get it because they didn't want to know, they were afraid that their baby might be affected, or they were too far to the facility. And just as an aside, most people, 90%, had dengue IgG living in this environment where there's endemic dengue. This is the map over time for the women, the 42 women that had the ultrasounds, showing when their illness occurred in pregnancy. This is when they had their infection, the week of gestation. And of these 42, 29% had abnormalities on the ultrasound. And you can see that it occurred across pregnancy, so it wasn't just in the first trimester. And this was something that is a little bit new in this study, is that there are problems in fetuses that are occurring when infection occurs even later in pregnancy. There were 2 deaths in this group, and they both were for babies where the infection occurred late in pregnancy, these 2 asterisks. So a few quotes from this paper. Despite mild clinical syndromes, Zika infection during pregnancy appears to have grave outcomes, including fetal death, placental insufficiency, fetal growth restriction, and CNS injury. Abnormalities were noticed in fetus of women who were infected at any week of gestation. Fetuses infected in the first trimester had findings suggestive of pathologic change during embryogenesis, but CNS abnormalities were seen with infection late as well. And then they had a very small control group here, 16 women that were tested negative for Zika, but none of them had abnormalities. So 29% of the women that had Zika during infection had an abnormality on ultrasound. None of 16 women who did not have Zika had abnormalities on ultrasound. We'll change over to the neurologic disease in adults and children. There's a report in an 81-year-old man who had gone on a cruise in an endemic area, came home to Europe, and developed meningoencephalitis, was in the hospital for a month on a ventilator, recovered. And this is his CT scan showing hyperintensity in locations in the brain. And he had CSF PCR with a cycle threshold of 34, and his virus was cultured from his spinal fluid as well. So again, building data for the relationship of Zika virus to neurologic disease in adults. This was a 14-year-old in South America who developed an acute myelitis, and she has hyperintensity here in the thoracic cord at the arrow, swelling, edema in the cervical cord, and again, they detected high concentrations of Zika on PCR in serum, urine, and CSF on her second day of admission, 9 days after symptom onset. Again, this was published online, I guess now 12 days ago. So a couple of different CNS manifestations. And then the one that Phyllis mentioned, GuillainBarre Syndrome, of which there have been many thousands of reported associated cases now. This is a study that just came out a couple weeks ago in Lancet from November, and this goes back to French Polynesia. So these associations are being seen not just in Brazil and South America, but in some of the earlier locations for the virus. So from November of 13 to 2 of 14, they noted 42 cases of GBS in French Polynesia. In the previous 4 years, so that's in 3 months, 42 cases. In the previous 3 years, for a whole year, there had only been 3 to 10 cases each of those years. As a side comment, there were concurrent epidemics of dengues 1 and 3 during this time. So they created a study with 2 control groups. They had the 42 cases of Guillain-Barré and either 98 or 70 in each of 2 control groups. One had no Guillain-Barré and was hospitalized. One had PCR positive Zika but without Guillain-Barré. This is the epidemic curve on the island. And you can see that the Zika peaked here at week 9 for an illness that is thought to be a post-virologic autoimmune type syndrome. Guillain-Barré should occur later, and it in fact did peak at week 12, the dark red cases here. Also from this paper, most of the Guillain-Barré patients had a clinical syndrome, 88% compatible with Zika. In general, it was 6 days before the onset of their neurological manifestations. Most of the classical definitions for Guillain-Barré would be 2 to 8 weeks after an infection. This is kind of early and makes you wonder about maybe some pre-existing flavivirus immunity speeding things up, dengue, for example. And then these patients had anti-Zika IgM in 93% of them. Only 17% of the control group without Zika had IgM antibody. And of course, there was no Zika RNA in serum by PCR because this is now outside that 5 to 7 day period when we expect to find the virus in blood. Most of the patients had pre-existing dengue immunity. All of them with Guillain-Barré were the acute motor axonal neuropathy Amann type with distal motor neuron involvement, which is more favorable. In fact, they had a faster recovery. At 3 months, almost 60% are walking without assistance. But interestingly, in general, this is felt to be Guillain-Barré, an anti-glycolipid or ganglioside antibody mediating this pathogenesis, but they really didn't find typical patterns of that in these patients. All right, I'm going to switch gears now. We've covered a little bit of the pathogenesis updates from the recent literature. Let's think about prevention, and I think actually this is good news here. We have some really good vaccines for flaviviruses. We'll start with yellow fever. There's a live attenuated, it's called yellow fever virus 17D that Sanofi has produced for years. It's one of the best vaccines that we have. It's been around for decades. Billions of people have received this live attenuated flavivirus vaccine. Dengue. Now, for the first time in 3 countries, Mexico, Philippines, and Brazil, there might be others that I'm not aware of, but in December of 2015, these 3 countries have licensed a dengue vaccine for the first time ever. This is tremendous news. You saw the numbers that Phyllis showed you, the tremendous magnitude of morbidity related to dengue. And this is interesting as well. This is made by Sanofi. They make the yellow fever vaccine. What they did, they took that well-established yellow fever vaccine, substituted in the pre-membrane and envelope proteins, just 2 genes from dengue into that for each of the 4 serotypes. So it's a tetravalent vaccine, made a recombinant vector. So it's a yellow fever hybrid with the dengue, expressing those 2 critical surface proteins of dengue. And it's been shown in a couple of studies now to have nice efficacy. This is just one of the papers. This is from 5 or 6 countries in Latin America, over 20,000 participants, and you can see that the percent infected in the control group is up here after about a year of follow-up relative to the vaccine group. So based on some of these efficacy data, the vaccine is now being approved in some of the highly affected countries. So good news there. We also have a couple of killed virus or inactivated flavivirus vaccines. There's the JEV, Japanese encephalitis virus vaccine, and TBE, tick-borne encephalitis virus vaccine, which are in clinical use and are giving us, I think, giving me a good feeling that we will be able to develop a Zika virus vaccine. I'll just mention that for another Flavie, West Nile, there are a number of vaccines in development. For example, NIAID has a DNA vaccine that's completed early trials and looked promising in terms of safety and immune response. Don't know the efficacy. And then Chikungunya, I'll just mention here that in our pediatrics group, as part of our VTEU, Evan Anderson, Paul Spearman, and their colleagues are getting ready to do a Chikungunya vaccine trial here at Emory, an early phase safety and immune response study. It's a recombinant vector, a measles virus that's been engineered to express critical Chikungunya protein, similar to what I described a minute ago for dengue. And this is, if you go to the WHO website, they like to put up what's in development to keep everybody up to date. And there are 20 entities working on Zika virus vaccines, as you might imagine. Very hot area. 18 companies, 5 states or countries. Some of those are collaborative, and they're sort of listed here. And you can see just about every type of vaccine that you can imagine is there. For example, there's a lot of interest in inactivated because it might be able to be used safely in pregnant women. As you know, live viral vaccines are contraindicated in pregnancy, so that would not be an approach that could be used for pregnant women. But there are a number of people working on the live viral vaccines, and of course here's Sanofi, who makes the yellow fever and the yellow fever dengue, the new dengue vaccine, and they're working on, I'm sure, a very similar vaccine for Zika. I'll just mention in passing that our Emory spinoff company, GeoVax, is also working on the Zika virus vaccine. There's a nice review of some of the vaccine progress from Jonathan Cohen in Science about a month ago. I will close here by acknowledging the group at the Travel Well Center, Henry, Jessica, and Phyllis, my faculty and fellow colleagues at the Hope Clinic, several of whom I've mentioned already, staff at the Hope Clinic who've been seeing these patients, the CDC and Georgia Department of Public Health. They have been collaborating with us to identify patients, to offer them participation in the research. Some of our Emory Vaccine Center colleagues who are working with us closely in this research project. So I'll stop there.
So I think we will open it up for questions. One has to do with the mosquito vector, and can you comment on the tiger mosquito, which is obviously, is it a vector? Do we know that, or is that still an unanswered question?
We know that Aedes albopictus is a vector of chikungunya. We know it's a very competent infector of arthropod-borne diseases, but we don't have good data to suggest that it will be a competent vector for Zika yet. I think the problem is how to control these mosquitoes more than anything else. When a tropical disease person, Fred Soper, set out to get rid of malaria in Brazil in the 1930s, he said it's impossible to get rid of mosquitoes in a democracy. And it's true, because what they did is they had to go house to house to house. And it was a crime, basically, not to let people in, to get rid of all of the standing water and to spray indoors and outdoors. So I think that we're hoping that Albopictus doesn't become a major vector of Zika.
Thank you for that interesting talk. I have a question from my own selfish perspective, which is transplantation, which includes transfusion. And last month, FDA said we're going to stop blood donations and transfusions in Puerto Rico. We're going to send blood from the mainland so that there's a safe blood supply. My impression has been that we are not seeing widespread disease in the United States because it's cold. And mosquitoes are not active, and I'm concerned that we'll see more activity as the weather warms up. And I'm also concerned with the fact that only 20% of those infected are symptomatic, which means people will continue to donate blood in the U.S. They will continue to be organ donors if they become potential organ donors. And with the kidneys being the most harvestable or procurable organs, and this persistence in the urine, if someone recovers from their acute illness or their non-acute or unknown illness, that we might start seeing transplant-related Zika virus especially. And as the West Nile, Emory was front and center for the initial West Nile transplant-associated cases. We know that those often have dismal outcomes in immunocompromised patients. And I would be curious to get your thoughts about some of these issues.
Yeah, beautiful comments, Marshall. I don't really have much to add. I agree entirely. The one thing I'll say is that since only 20%, it's thought currently, only 20% of people have symptoms with their infection, that means there will be a large number of people that we won't identify potentially. One thing that's unknown, so we talked about the many unknowns, is whether those people without symptoms have a similar pattern of viremia, for example, of shedding in urine, of sexual transmission. These are some of the things that need to be studied, that we would like to study, at least in the context of returned U.S. travelers. So I had the same thought about urine and kidney. I didn't think about transplantation, but there must be something going on about persistence in the renal system with this virus as well. So I think that your points are excellent.
We do have a question from one of our other sites. So in regards to the Pacific Islands, where the Zika prevalence was, I think, as high as 75%, do you also see any microcephaly or teratogenic effects in those populations?
That's a very good question, and that's one of the concerns right now with, there are several, with regard to saying that microcephaly is just caused by Zika infection, and these other things are just caused by Zika infection, because it's just been in Brazil predominantly where these cases are being reported. And the issue is whether it's just that surveillance might be so poor, or there's a lack of a willingness to come forward and report cases of these kinds of problems elsewhere. And I think it's just a matter of time before we figure out whether there are cofactors or whether there's something else going on, or it's just very late to be reported.
Well, we very much appreciate this update. That was fantastic. Thank you very much.